Working really well. So, hello and welcome to the 10th Annual Community Health All-In Breakfast Summit. I can't believe there has 10 of these already. My name is John Koenigsnecht. I chair the corporate practice at the law firm of Crowell & Mooring, and I'm the very, very proud president of the board of Community Health. I'm honored to be here today and to be working with Community Health, frankly, to ensure access to health care for all Chicago residents. So hopefully you saw some of the statistics up there. Community Health is an amazing organization. It's one of the largest volunteer-based free health clinics in the country, and it's here in Chicago. We provide primary care, over 25 specialty care services, prescription medications through our on-site pharmacy, behavioral health and dental services, health education, and lab testing in 3 languages, in 3 locations in Chicago. We provide these to low-income, uninsured, and underinsured adults, and here's the key, at no charge. And donations from generous people like you. "30 years ago, Community Health was founded by an incredible man, Dr. Serafino Garella, who saw and brought together his friends, colleagues, financial support, and an entire community to meet the need that he saw in our communities. Serafino founded Community Health on the belief that no one should go without health care. The staff and the volunteers of Community Health are exceptional stewards and continue to innovate to meet the needs of the patients and communities we serve every day. Nothing is too big for Community Health, and I understand how big that statement is. Thank you for being here, and thank you for supporting Community Health. I would like to especially recognize our many sponsors who are supporting today's event, including the Joseph and Bessie Feinberg Foundation, Northwestern Medicine, Midwestern University Chicago College of Osteopathic Medicine, Walgreens, Meridian Health Plan of Illinois, Altair Advisors, Advocate Health, Third Horizon Strategies, and many others. It's quite an incredible list. I encourage you to visit our website at, let me get this correct, allin-chicago.org, that's allin-chicago.org, to see the complete list of sponsors, to read bios for our incredible speakers, and to check out more events in the series that will be coming up in the next few months. You can find a QR code on your table and on the screen to access the site. The goal of the series, the All In Chicago series, is to bring together leaders from many different industries and segments of our population to talk about how we can work together to ensure that every resident has access to the right care in the right place, and at the right time. Community Health has been hosting all-in events discussing access to healthcare since 2015. This is the 10th time we've hosted a breakfast summit, and I hope all of us come away with new ideas every time. Today we'll be focusing on more than 38,000 migrants who have been bused or flown to Chicago from border states in less than 2 years. Many healthcare providers, community organizations, and individual volunteers have banded together with city and state leadership to provide services and support to these individuals who do not have homes, work permits, or health insurance when they arrive. I've been proud to see Community Health. That is an understatement. I get choked up when I think about Community Health on the front lines of these efforts. And today we welcome an incredible panel of leaders to discuss how we can make sure that healthcare is accessible at every stage of the new arrival experience. It is my pleasure to introduce the moderator of this conversation, Kristen Schorsch. Kristen is a reporter on WBEZ's Chicago Government and Politics team, where she covers Cook County and specializes in public health. Her stories have been on the air and online nationwide through NPR and KFF Health News. Most importantly, she examines the ripple effects of the U.S. Supreme Court overturning Roe v. Wade, the potentially brewing mental health crisis among migrants, and the power and influence of Cook County politics. Welcome, Kristen, and take it away.
Can you all hear me okay? The mic's working? Yes. Okay, great. Thank you all. Good morning, and we're looking forward to the conversation today. One quick housekeeping item. If you have a question for the participants, we're going to get to those after we have a conversation ourselves. But please submit your question through the social Q&A. There's a QR code on your table, might be under your plate. That's where I found mine. And then we will go through all those questions and hopefully get to as many as we can during our conversation. So now I'm pleased to introduce our panelists today. Dr. Evelyn Figueroa is the director of the Pilsen Food Pantry and a key advisor to the Global Migrant Health Team. That's a group of medical students who offer street medicine services in police precincts, airports, and shelters, seeing a need to bridge social gaps that were hindering patients' health. Dr. Figueroa developed anti-poverty programs in Pilsen that address food, housing, education, and discrimination. Mario Garcia is the executive director of Onward Neighborhood House, a settlement house and immigrant welcoming center on Chicago's northwest side. At Onward House, Mario has overseen the transition from West Town to the Belmont-Cragen neighborhood to meet the needs of the population served, and the organization has continued to expand services offered under his leadership. Dr. Simbo Ige is the new commissioner of the Chicago Department of Public Health, but her career spans nearly 2 decades of making public health and health systems more accountable and more equitable. She previously served as the managing director of programs at the Robert Wood Johnson Foundation. Steph Wilding has been CEO of Community Health since 2019, where she has successfully steered the nation's largest free clinic through the COVID-19 pandemic and migrant response efforts, while simultaneously growing in locations and services. Steph has committed her career to organizations that empower communities to overcome broken systems and lead healthy, fulfilling lives. Welcome, panelists. And just a reminder, if you want to start popping your questions in, take a look at it. Okay, so let's get started. So I'd like to hear from each of you about this. What is the current state of the new arrival situation from your perspective? And what is your team specifically focusing on right now? Steph, do you want to kick us off?
Absolutely. Good morning, everyone. It's fantastic to see you all on this beautiful day. As I said to a few of you, I was worried it'd be raining today and we wouldn't get the views that we have, but now we do, which is fabulous. So at Community Health, we have had sort of a phased trajectory in our new arrivals response. So beginning in May of last year, so just about a year ago, we were approached by the city, including the Chicago Department of Public Health, asking if we could provide health care to new arrivals who were being placed in the police precincts. And I think this is a great example of what makes free clinics unique, is that within 10 days of connecting with the city, we were actually in a precinct providing care. And the reason I start with a year ago to talk about today is because what we learned through that experience was where our role was best suited, which is to serve as that key medical home that is the follow-up location from an initial triage and assessment. So at Community Health, what we are focused on currently is ensuring that new arrivals, some of which, many of whom have been bused here, but folks are also arriving on their own, have a medical home. And you heard all the services that Community Health is able to provide, from primary care, specialty care, dental care for the uninsured, which we know is an extreme challenge. And so from our perspective, the demand remains significantly high for services like what we're able to provide, a key medical home where a patient can receive everything that they need. And every day we have a wonderful operations and clinical team working really hard to be creative about how we build access. But I think from where we sit as a medical home, that has been the largest need. It continues to grow. It is something that Community Health is trying to be creative about meeting. But it continues to be a challenge, I think, for new arrivals to have that medical home, which is so critical.
And Dr. Ige, what would you say is the current state of the situation for arrivals?
So as the public health department, our job in public health is the 3 Ps: prevent, promote, and protect. So prevention of infectious diseases is a primary goal, because when people come together in large numbers, it is important that we identify the threats and prevent. Then promotion of access to services and resources. So the medical home, making sure people have their health insurance, know how to navigate the US health system, and know where to go when they find their permanent homes, is another component of our work. And then protect, that's protecting the food and the environment. So making sure shelters are safe, making sure the food handling is safe, that's another component. So these 3 Ps are a constant part of the work. And as you can, you've probably heard in the news, there are periodic outbreaks of infectious diseases, which tends to happen in congregate settings. And so that's a major part of what we're handling right now, as part of the 3 Ps: prevent, protect, and promote.
Okay. And Dr. Thoreau?
Good morning, everyone. Thank you so much for coming and for supporting this important conversation. Thank you for having me. So I'm Evelyn Figueroa, she, her pronouns, and I'm the founder director of the Pilsen Food Pantry, and I'm also a professor of family and community medicine at University of Illinois, and also the president of the medical staff at UIC in the hospital. So I have a lot of different perspectives. It has been a challenging year. It's for us at the Pilsen Food Pantry, it's been a challenging 20 months since we've been standing up migrant services in various settings, helping run shelters, the shadow shelters that were privately run in Pilsen. I work closely with Alderman Siccho Lopez, and Pilsen is a very typical place that people that are Spanish speaking want to live in, right? It is now highly Chicano barrio, which it has been since the middle of the last century. So I live in the neighborhood. I went to UIC for medical school. So I've been serving Ward 25, which is the ward that Pilsen's in since the mid-90s. It's changed a lot in the past 20 months. It's changed significantly more in the past year. Healthcare access is a real issue, especially for people that are not, that are ineligible for insurance, because that's really what we're seeing. We already treat a very large immigrant population. 10% of people in Illinois, and 5% of the labor force are uninsured and undocumented. So this is what staff does, is life-saving. And we've done our best because it's really not possible for wonderful organizations like Community Health to fill the gaps. These are giant gaps where everyone that's all in is really important, that we all stand up and do what we can do. So at the Pilsen Food Pantry, although people made fun of me for starting a pantry as a family doctor, it certainly came in handy during COVID when I had to do all of those protective measures. And of course, it's changed the focus. Food is medicine, and everybody knows that good food shouldn't get thrown away, but neither should other important things. And we are in a very consumer-driven environment. We have so much excess that we enjoy, and there really is enough for everyone. So I think that's the biggest thing I've learned in this folks. So we have several different programs at the Pilsen Food Pantry, and then all of that work ties in to my work at the University of Illinois, where I also direct community engagement for family and community medicine. So, and I'm very lucky to have my dream job with a boss who lets me do all these things, since I am not, I do all my work for the pantry in kind, and then use it as a learning playground for my students. I really don't want them to do dashboard surveys and learn about healthcare and social determinants that way. I want them to get their hands dirty and look and notice that the person across from them is wearing something similar and looks similar, because we really, we disguise poverty, and it's very stigmatizing. So everyone tries to pretend they're doing better than they're doing. But we know that when you have less and too much less, you live and suffer a lot differently than someone who has the basics. And that's really what we do. So besides food, our volume at the pantry has increased by over 200 people a week on average. We are open 5 days a week. We offer fresh foods, including produce. Produce is very expensive. We have run out of eggs. We are spending $2,000 a month on eggs at this point, which we never thought we would, but we want to make sure that people get there, don't do worse. Every year that you're food insecure, you have a 10% greater chance of becoming diabetic. Your chance is double of becoming diabetic in 10 years. So we really want to prevent that downstream suffering that is not necessary when we have the largest produce hub in the Midwest, a mile from the Pilsen Food Pantry, and no policy in Chicago about food waste, or nationally, but that's tomorrow's panel at the law school. So we have that, but then the other thing is our free store. So we have a free store that used to only have 60 clients a week, that now averages 300, because we provide jackets, clothing, underwear, socks, sleeping bags, yoga mats, toys, blenders, anything that we can fit into our building. We also moved in the past year, and we are the closest migrant serving community-based organization to the Halstead shelter, which is notorious and very, very large, and not appearing to be closing anytime soon. So we're doing everything we can to try to provide resources to those who come on foot. For medical care, our organization is the incubator, and I'm the lead advisor for the mobile migrant health team. We did 9,000 health screenings at police stations, saved the health system well over $1 million by doing that. It is all run by medical students with volunteer attending resident physicians. We've tried our best to support as we can at the shelters. It's a lot more challenging to enter into those because of safeguards that are in place, but we were able to help with the measles outbreak, and we continue to do high-risk case management for a lot of people with complex needs. And then lastly, at the hospital, of course, I'm trying to connect and educate our hospital community and help navigate folks through, because when these outbreaks occur, there really aren't appropriate or sufficient isolation spaces. That's always going to be an issue in congregate settings. So for me, I also get to really go from very transactional community-based to very high level at the hospital, and I'm very grateful for it. And I hope that we will continue to try to make sustainable changes that get us ready for the next pandemic, the next crisis.
Thank you. And Mario, what's the current state of the new arrival situation from your perspective? What are you working on?
Well, I think before I go to that, I would like to add a little bit of context to the current situation that we're having. As a community-based organization, sometimes we begin to see what's happening in society before it becomes a crisis. I remember a few years ago when we had the housing market collapse, we started seeing construction workers coming to our food pantry much earlier before it became news all over the place. So just like with that, in terms of the immigration, we started to see at Onward House a number of Venezuelans, Ecuadorians coming to Belmont Cragen. Our kids in the preschool started to, from other ethnicities, Latino groups, started to become much more South American. So we knew that something was starting to happen in those countries. And obviously things have gotten worse. That came when August 31st came. We were one of the first organizations that were called in to help with the first couple of buses. Our staff had been handling everything from translation at that time. And at that time we had a welcoming center. We had just started a welcoming center for immigrants and refugees. And I think it started on January 1st of 21. And whoever came, we will welcome them. We will provide the services. Hey, I need food. Here's food. Oh, I need to navigate the system. I want to enroll my kid in school. Here's what you need to do. All kinds of things. And we just opened the doors and came in. Once the two buses started, we went from one employee and $75,000 to now we have 18 staff members and a budget of $1.3 million. And I want to give a shout out to the government because the state of Illinois has been very supportive in funding us. And over the last year, we have to be doing a budget revision every 3 or 4 months because can you take more? Can you hire more case managers? So right now, we have 2 teams of case managers, one at our center that are able to work with people that have appointments, because that has also shifted from, hey, come in, we're a community-based organization, the doors are open. The numbers are so large that we had to set up a appointment system. So now we're operating with the appointment system, right? So we have like 6 or 7 case managers at our site, and then we have another group of 6, 7 case managers at one of the shelters. But then folks from all the shelters in the city of Chicago are just dropping by. So we're a community-based organization. We don't turn anybody away. So our case managers are working with someone in one of the classrooms in whatever they can find space, because that's the other issue for us as an organization. We have so many space that was created for 6 people. Now it's whenever everybody's there to data entry and training and those kinds of, we have 18 people in that kind of space. So that has become overwhelming. We have gone from like I said, a team of 1 to 18 people, but the numbers are huge. They're doing the case management with the appointment. Somebody walks in, and then we are also providing a kit for hygiene products, food, clothes, shoes, and then setting up an appointment. We do triage in case there is some major issue that may be squeezed. And I want to give a shout out to, I believe I'm giving a shout out not only to my staff, but the staff of the organizations here. I've seen people, you know what, it's 6 o'clock and I have my appointment, but I'll stay more time in order to take this other person. So part of being overwhelmed is not just the numbers, but I think the staff, they have heard some horrendous things, stories. Early on, we started hearing from children that they had seen dead bodies on the road here. So it's overwhelming in terms of the work, in terms of numbers, stories, but at the same time that we have been able to organize internally more effectively, it's just not enough. And we're also dealing with the chaos of the entire system, trying to deal with the numbers. But also we have a great relationship with CommunityHealth, that if it weren't for them, we would not be able to also provide health services. Because there's a great synergy, they have a space in our center, so they refer people to our case managers, and we take people from the case managers to them for health services. I remember just Stephanie calling me one day because she went to the police station and said, Mario, just wanted to let you know that on Friday we're not going to see our regular patients, we're just going to bring people from the police station. That's the kind of synergy between the organizations and the kind of work that we need to do in order to provide support to the families. And my last point is that the number of 38 is just an estimate, because people are coming on buses, but they're also coming in different ways. I wouldn't be surprised if the actual numbers are around 50,000 people.
Okay, thank you, Maria.
Dr. Figueroa, can you tell us a little bit more about the mobile migrant health team? How it started, what that experience on the ground was truly like for people who maybe don't have a sense of what the students have been doing, and what they're doing now, year and a half into the situation.
MMHD was the brainchild of a now rising third-year medical student, so a first year who said that she was interested in emergency medicine. Now it's family medicine, so I'm going to keep trying to recruit everybody to family medicine. And she was part of Chicago Street Medicine, which is a long-standing street-based volunteer medical group that has several chapters throughout Chicago, but very English-speaking focused, because most of the people experiencing homelessness in Chicago are Black men and speak English. So did a lot of great work with them, and as we began noticing people living outside that were related to the Texas border migrant crisis, Sara Izquierdo, the co-founder, who is of Ecuadorian descent, was very moved from an immigrant family, and felt that Chicago Street Medicine didn't have the focus to address the different needs. The folks that are chronically homeless have a lot of issues regarding dentition, wound care, chronic diseases. They tend to be older, and then a lot of trauma, of course, related to usually incarceration, serious mental illness, etc. The folks arriving from the Texas border were younger, tended to be families, some disabilities, but a much healthier population, but monolingual, other language, mainly Spanish, and we know there are some French Creole and Northern African dialects too that we've encountered quite a bit, but mainly Spanish speaking. So she gathered a bunch of folks who were bilingual, because obtaining interpretation services, as we will all tell you, is very, very challenging. But fortunately, UIC has one of the most diverse medical schools in the country, many Black and Latinx and some Native American students, and just very well organized student organization. So she recruited from there, and then tried to find a preceptor crazy enough to do it with her. So someone introduced us by email. She showed up at my house a couple days. I went Cinco de Mayo for the first time to a police station, and found someone who was out of his insulin, that needed a glucose meter, that had high blood pressure, like serious things, and then a lot of people with colds at Station 12. And fortunately, Sarah wrote to me that weekend because there was no way I could extend myself to be everywhere. I get called a lot by the alderman as one of the only physicians that he has on, a speed dial. So Sarah came along. We packed supplies. By way of training as a family physician based in Chicago, I've encountered a lot of people experiencing homelessness. UI Health is one of the biggest Medicaid providers in the state, and so this is always an issue that's been important, and I've written a lot of curriculum and built it into the training program for the family medicine residents, and in 2020 ran 4 COVID isolation units at Pacific Garden Mission, which is the largest homeless shelter in the Midwest. We sheltered in place to help CDPH to not overwhelm our hospitals. So I had a lot of background in emergency crisis management, very much baptism by fire, but still. And so Sarah and I really went to doing the stuff I did at PGM. We were repacking over-the-counter meds and making sure the labels were in Spanish and all the stuff. And we made some backpacks. Now we have really fancy, cute bags that are way more organized than what I tried to get them to lean by, but which is fine. They fundraise. They're wonderful. And so then they started running to the stations. There are 23 police stations in Chicago. They have visited at least half of them. We worked a lot with OAMC to try to make a schedule. It's really important. So I'm really the guardrails for them who want to just whack-a-mole everything. And I have to say, you're thinking of the long game, and you need to sustain the work that you're doing, and people need to know when to expect you. You can't just show up for one person with a cough. Everyone needs to know you come on Tuesdays and Saturdays, whatever is the schedule. People need that stability and that structure, and that also was helpful for them scheduling. So eventually they had a 6 police station route that they were running twice a week, doing hundreds of visits. And because again, I run a 501c3, they were able to incubate. They have their own separate line item, and I continue just to help with MOUs and a lot of high level medical advice. But they're really a wonderful group of young folks, and they give me so much inspiration for the future. It's as exhausting and weathering as all of this work is. To see their optimism and their question of the construct and the status quo is what really fuels me. After the police station sheltering closed, we were supposed to go to the landing zones, but fortunately the landing zones didn't end up being as crowded, or they were briefly crowded and then not. There are lots of bureaucratic delays that NMHT has experienced. There's no way that the city can be position to have, just like we're talking about with staff increases at Onward House, we have not increased staff as much and had to just keep doing more work. And the same thing is for the city that has not been able to adequately staff and also just to have that emergency management training that you hope to never have to prepare for. MMHT has kept in touch with their families. We keep a very concise registry. We've collected data the entire time to show the ROI on the work that we're doing, and they're really working a lot through consultation now. Unfortunately, we've not been able to go inside of shelters, and that's made it challenging, and a lot of that has to do with how new the organization is, I don't think that the city's really used to something this grassroots. They typically will collaborate with organizations that are much larger and with longer track records, like CommunityHealth, which is great. But definitely at shelters, as much as you'd like to get people to federally qualified health centers, this issue with transportation and language is huge. People are speaking or communicating through WhatsApp, and because they don't have cell service, so they're using the Wi-Fi inside of their shelters if they're fortunate enough to have it, or they're going somewhere that they can borrow the Wi-Fi to communicate. So navigating someone to a medical home is very challenging. So we do a lot of accompaniment for folks, helping them schedule visits. CommunityHealth actually has allowed our MMHT team to directly schedule visits. Getting that done at UIC took 6 months longer and I'm president of the medical staff, so it just shows how bureaucratic things can be. So we do a lot with case management, not as well as a case manager could, because they're medical students being taught by a physician, which is not always the best model, but we make with what we can, and we want to continue to help.
Okay. So the mobile migrant health team has referred a lot to CommunityHealth, right? You just established that connection there. So Steph, can you walk us through how those referrals changed in any way the way that you ran the clinics? Like, did you see a lot more specific illnesses or certain health needs, staffing issues? Kind of walk us through how that changed things for you.
Yeah, I think I want to pick up a couple of themes that I think we're hearing and tie it back to our work with MMHT. So I think one is around collaboration. Mario mentioned the way that we work together. I'll talk a little bit more about the MMHT collaboration as well as our work with the city. Collaboration in a crisis is key, and that's certainly something that we learned during the pandemic. But I think the other piece here is the value of volunteerism in the midst of a crisis. That was certainly, for example, how Chicago had such outstanding presence in vaccination for COVID-19. Is these large locations were largely staffed by volunteers, including a lot of the work that CommunityHealth did. And so I think the opportunity that we have in rethinking, as Evelyn just mentioned, how we utilize and deploy volunteers is so critical, particularly in any crisis, but especially a humanitarian crisis, which I think when we think about the border crisis, we think about it as something that's very far away, but the fact is that it's been happening in our city for the last 20 months, and particularly when folks were at precincts, was extremely challenging. So I wanted to touch on those two themes and talk about our work with MMHT. And so we became aware of MMHT when we were going into the precincts and providing care as well. You all have fancy backpacks. We had suitcases and folding tables. Never underestimate the value of an overnight Amazon purchase. And really the methodology of thinking smarter, not harder, and while we were in the precincts, understanding that assessment and triage has its limitations. We could hand out only so much over-the-counter medication before someone needed to be seen in our clinic because they needed medication. That story of a diabetic patient needing their medication now. I recall a story that was shared with me by one of our volunteer providers and board members, Mary Harrington, about a patient that she had seen who had 3 days left of her medicine for her seizures and was living in a police precinct and did not have $1 to her name to be able to even do a GoodRx coupon. And if we had not been there to triage and assess and get that patient into our clinic immediately, what would have come of her? And so we understood the power of triage and assess, and we understood that there were amazing organizations like MMHT where this is their focus and specialty. And in the spirit of the lessons we learned from the pandemic about the power of collaboration, but not just, hey, let's refer to each other, but really how do we break down the barriers between our two organizations so that we are working and moving towards a common goal, which is to ensure that people have health care at every phase and stage of their experience as our new neighbors. And so that is when we began experimenting, and we started this with MMHT, with holding slots on our schedule that were specifically for MMHT and now many other providers, where they could go into our system and directly schedule. Cutting down that middle person, we were able to provide them with transportation cards, which, it still isn't enough, but it helps to break down some of those barriers. And this idea of not overthinking the process so that you can build access to care. And so what we have seen at Community Health as a result of our partnership with MMHT, as well as many other providers on the ground, year over year, Community Health has seen an 85% increase in new patients seen. So we have seen a significant increase in demand. This is the longest patient wait time we have experienced in recent history. And I think, I'm not a clinician, so I will relay what our amazing clinicians tell me about what we're seeing is, we're seeing a lot of chronic disease management, which is typical for the patient population we serve, which is why it's really critical that patients find a place like Community Health where they're not only seeing a primary care provider, but they can also see a specialty care provider. For example, that patient I mentioned was able to be seen very quickly by our neurologist. In what other environment would a person who is uninsured, without $1 to spare, be able to see a primary care provider twice in a matter of days and a neurologist and receive all of their medication completely free? And then of course we see a lot of upper respiratory infections. I think any medical provider will tell you chickenpox has been just a theme of what's been seen. And then, certainly, proud of the work that MMHT and the city have done around vaccination for measles. And, I just want to really, again, kind of echo what Evelyn said about MMHT as my final point on this. And, I talk about the power of volunteerism. I talk about the power of strategic collaborations, but also none of that would have been possible. We may not have even thought to do that if it had not been for these really ambitious young people who are also pushing us to stay creative, pushing us to continue to be flexible. And we had a chance to have Sarah speak at our last board meeting, and I've had the absolute honor to talk to her many, many times. And the ways in which they're pushing the boundaries in how we create access creatively is really remarkable. And they have pushed, I think, I would say the city, I would say community health in all of the best ways. And so just wanted to give a major kudos to them because, like Evelyn, they keep me hopeful. And hope is a discipline, and they keep that discipline strong.
Let's switch to mental health, which I was gonna ask about, but it's also a super top question among you all as well. You know, the migrants has gone through some really harrowing journeys. Mario, you mentioned children witnessing dead bodies. I've heard some really horrific stories. I'm sure everyone here in this room has, right? There are not enough mental health providers to take care of this population or the general population in Chicago. So Mario, I'm curious if you could talk to me a little bit about the stressors, the mental health that you're seeing among the migrants and how you all are helping, because we just don't have enough people to provide the treatment.
I don't consider myself an expert in Latin America, but I am from Guatemala. I grew up there my first 12 years from Guatemala, and typically in Latin America you have very elite, wealthy group, which tends to be pretty small, and a narrow middle class, and a wide low income population. So access to medical care in our own countries are very limited. Only those who can afford it. And then for the middle some, but for the larger population in those countries, accessing healthcare is very limited. So we are facing a population that's coming that's also a wide range, professionals to laborers, education level from PhD to I just got to 3rd grade or 6th grade. So those are folks that are coming already with trauma from their countries. And many of those folks also have left. They have left Venezuela or Ecuador and have gone to Peru or other countries, suffered through COVID there, limited access to medical care, because now they're migrants somewhere else. And then the trauma of COVID, and then the trauma of the trip to here, and they have gone through horrendous, from children to adults. Women have been violated, robbed, lost families and members on the way here. So not only they have the trauma from their upbringing in those countries, the trauma of those journeys here, and then the treatment here in this country, going through the bureaucracies. Our first bus had an older man with a broken ankle, and nobody had taken care of that. So that's some of that trauma. There is the trauma we're adjusting to a new culture. We have in our lobby, we've seen moms breastfeeding. To us, especially our case managers that reflect the population that's coming, that's a natural thing. But coming to this country, other people, should they be doing this? Adjusting to the food could be a stressor. Navigating, moving around the city, dealing with police stations. Many come from places where, the police, the army, people of authority, politicians are some of the oppressors, aggressors. Now they're stuck in a police station. So those are some of the kinds of things. Isolation is a huge thing. It's a huge thing. You may think, oh, you have 500 people in a shelter, how can they be isolated? That's an additional trauma. When I came to the States, we had family here. We came one day, a week later, both my parents were working, so we had family, and they had friends, so there was a network. Here, last Christmas, for many of them, was the first time they got a gift, because we make sure that the kids and the family have gifts. And I want to give also, volunteerism in a time when people of authority and have been given the privilege of having certain responsibilities in our society are trashing people, calling them garbage. At the same time that I sit there on my home watching those people on TV, members of the community have, with little means sometimes, bringing food to our house, bringing clothes. So the spirit of volunteerism has been alive. And I think that has been a sign of hope, while some other people have used this as a wedge issue in our society. But so those are some of the stressors that I see, and I think this is going to be a huge problem for the next decade or so, if we don't take the time to address those issues.
Okay, thank you. Does anyone else want to comment though about how we meet that need, right? I mean, if we have a shortage of providers, a persistent shortage, how do we help people get through the trauma?
Yeah. So just to give you a little context of this crisis, Chicago is a city of 3 million people. In addition to the 38,000, almost 40,000 migrants that we are trying to find healthcare for. This is also a city with 68,000 unhoused people, 90% of whom are Black. And so we have 38,000 people, many of whom are brown, also trying to get healthcare. In addition to that, this is a city with a long-standing inequity in getting access to care. So there are layers and layers. There is already in Chicago 80% of people with unmet behavioral health need. 1 out of every 4 Chicagoans have a mental health problem. So we can focus on the supply. The demand over the last 20 years, the demand for mental health has outpaced the supply by almost a factor of 10. And I'm sharing that to say the demand just keeps increasing within the context of reducing supply. There is a nationwide shortage of healthcare providers, of public health providers. People on the ground who are doing this work, we cannot continue to work at this pace for long. People get burned out and then they leave. So the larger conversation we're having in public health is how do we reduce the need for healthcare writ large by focusing on the factors that push people into crisis, and how can we solve for those issues? So there is a huge mental health crisis, and on top of that, we now have traumatized people that have spent years in transit with the expectation that United States is the land flowing with milk and honey. And they land here and they are slapped in the face by hostile, aggressive forces that are unwelcoming. So imagine the kind of trauma. You have held out hope, you have waded through rivers, you have been molested and victimized on your journey, but the hope of I am going to get somewhere and it's going to be better keeps you going, and all of a sudden that hope crashes when you arrive here and you are sleeping on the ground, maybe in worse situations than where you were coming from. Without now that hope has. So people need a lot of support to rebuild that hope and to be given a sense that you can make it still, in spite of all of these problems starting. So we are doing a lot of work. I know people say, what is the treatments that we're providing? But a huge part of what I would call treatment is helping people know where they can get support and resources and connect them to how they can stand on their feet, because that's what gives people hope. That's what preserves people's dignity. Nobody wants to be on the street corner begging for food for their children. So how do people get employment? How do people get connected to services? These are the things that help restore people's mental health. When you can't feed, you don't know where your next meal is coming from, there is no amount of treatment that can make you whole. So I want to also highlight that that is a huge part of mental health, getting people to sustainability and getting people restored in their dignity and getting people connected to resources. And that's the shift that we have brought from the public health perspective. There is a huge narrative around healthcare and healthcare and healthcare, but that is very downstream. We also need to go upstream and figure out what is it that teaches people into crisis and how can we meet those basic needs so that people are better protected mentally. So that's my contribution to that. Not that we also provide support for mental health providers in the shelters, that support. They're there once a week across all the shelters. And then at Belmont Cragen also, there is screening for mental health issues and connected to resources. But we have to acknowledge there's just not enough providers to meet the need.
Dr. Figueroa, did you want to add something?
I did. Thank you, Dr. Ige. I agree with all your points. The thing that I talk about a lot at these types of sessions is in order for us to be a sanctuary, in order for us to give respite, we have to all agree on what the basic human needs are in that type of sanctuary status. Sanctuary status to me is not just not calling immigration and forcibly deporting people. Sanctuary to me is housing, clean water, clean air, warmth or air conditioning, not air conditioning, but at least a fan in August. Access to healthcare, getting kids to school every day, clothing. These are the, I think that the way to go back, I'm not an MPH, and my nonprofit is the biggest capstone project I will do in my life, and I wish I had done my MPH because it's not fun to learn on the fly like this and to not look as broadly and have blind spots. But when you're doing the best that you can, if you're not aligned in what's important, it makes it very difficult to not have that wedge be driven between us. And I always think about when I do trauma-informed care that housing is trauma-informed care and food is trauma-informed care and education is trauma-informed care. And if you think of Maslow's hierarchy of needs, which I teach in every slide set that I do, it's like if you don't have these basic things, you can't have anything. Your self-efficacy is gone. I mean, I know medical students who are struggling with violence in their homes and safety issues, and how are they going to sleep and go to school and learn the same way, even though they would make the most wonderful doctor ever? We are losing out on so much human talent, but also throwing away some people that are disabled because of a lot of our ableist attitude. You know, Mario was talking about how people from Venezuela, and you know, this tends to be who we talk about the most in this because it's about 70 to 75% of the people that have come. But they did go to Colombia first. Colombia has sustained a much larger wave of Venezolanos than anywhere else in the world because it's next door. And they really did arc and get, they were outsiders there too, working for less money, stealing people's jobs, but leaving Venezuela because nearly everyone is unemployed. They printed more money to support the economy, which of course devastated the economy. They come from, you can't work. So even if the weather is better, the sleeping conditions are better, if someone in your family gets sick, they have a shortage of 85% shortage of medications. You're bringing IV to the hospital if someone needs it. Where do you get it? It literally doesn't exist. So they're coming here and crossing and getting through the Darien Gap, and then they're in a detention center in Mexico, which I don't know if you all know, but now there's a lottery to get into the United States. So, and you have to have a cell phone because it's all app-based. So you can't get notified to cross into the United States unless you have a phone to which you can be notified. That's every day that happens. They sleep just like police stations. They're tents and it looks identical. And again, trying to work and hustle through a different environment, different everything, processing what's not being able to really process, being harassed by your family back home to send money back, because that's what everyone is coming to do. And then getting here, and of course the disappointment is real. You thought you made it through the worst. You thought the Darien Gap was the worst, and then you get to Mexico detention, and that's worse. And then you get to the border and that's worse, and then you get to whatever the first city is, and you're met with a lot of hostility. So for us, the way that we try to address mental health is through providing, acting in solidarity and not charity, helping empower folks, really recognizing that consumerism and the abundance that we have, and that's really what I confront, because I think a lot of the mental health issues coming here also have to do with misinformation and people really not believing that there is enough for everyone. And that for me is very, very important for me to take my position of power and to really make sure that I speak out to folks that are disparaging, and to do my work to learn about it. When you tell someone that the average weekly salary in Venezuela is $8, people are very motivated by that. The average weekly salary for an entry level in Mexico is $120 a week. These are not fun numbers to read. We think about what we just spent on the food here. We have a lot, there's something about money that makes us think we need more money to be important. And these are all about our values, and it's really for us to think about not keeping up with the Joneses, and to think about, should any person live outside? Because we would solve so many problems if we all could just agree. I have a staff member who was my patient for years, who I knew as just a sick person, and her sick husband with diabetes, and they lived across the street from the Racine and 21st Place shelter, shadow shelter we ran with the aldermen last summer. And I needed someone to help. I built these little, I call them the tienditas, and so there was one that had food stored, clothing, bedding, and then we had a medical closet that MMHT, and I ran out of there. And I needed someone to run the tiendita de ropa, the clothing one, and I knew she lived across the street, and so I offered her a job because we had gotten some migrant donations. I said, I can help you with this, and I moved her over to the pantry eventually. This is a person that was going to who got emergency funding, because during COVID, of course, everyone in her family lost her job. She had an aneurysm years ago and had a leg, her leg didn't feel the same. And she got very depressed from it, of course, because she had an aneurysm when she was in her early 40s and wasn't expecting it, and has well-controlled diabetes, but still, you're like, am I dying? I'm only 40 years old. So, she almost got evicted from their place. They got $11,000 in emergency funding. Thank goodness, because I had no answers to give her as a family doctor who runs an anti-poverty nonprofit, because those lotteries for rent relief are here and there. They are not constant. And again, this all gets funded out of us not sure if housing should be affordable, and all the other stuff that's happened, gentrifying Pilsen and Ukrainian Village where Community Health is, and Logan Square where my family came from, and Lincoln Park, and everywhere in Chicago has basically been gentrified, right? So, or almost. Anyhow, I'm bringing her up because I hired her last July to work for us. She signed on a house yesterday. She bought a home. She was almost evicted a year and a half ago. She worked for us for, how many months is that? 9 months? 25 hours a week. I paid, everyone in my staff gets a living wage, so no one gets minimum wage, but it's $19 an hour. It's not amazing. There's nothing, how would I live, right? And then a couple months later, because the donations were strong, because no one funds a free store, just so you know. There are certain things you can get grants for. I think that you noticed in the beginning, they talked about how much is private donations for community health. A lot of people think, they're like, oh, there's a grant for that. There's a grant, you're like, no. There are donations and there are funding cycles, but everyone's competing for the same pot. So if you have a good streak and you think you're strong enough, you add a person on. So I added her husband on, and what a transformation. She's off her antidepressant. She says she feels great every day. She said, I thought I'd never work again. I identify with the migrants, and she's a godsend. She's amazing. And so you think about what trauma looks like, and trauma looked like that disabled patient that I had, who now is like a boss, a 110-pound boss in the Mercadito Gratis. because she can communicate with Cantonese speakers, which I still don't understand how she does that, but it's all through, mining. But that's what trauma informed care looks like. That's what mental health looks like. It's really addressing basic needs and then working creatively. Once you have people in stable housing, you can make talking circles. There are lots of other ways you can have people garden together and have coffee right afterwards. There are lots of, all of the research shows that if you get in touch with nature, there are all these other ways. But when we keep pushing through the same bottleneck of thinking that everyone needs individualized therapy, and of course you do. I've had therapy for specific issues. I get a tune-up. I get out of the tune-up. But until we address these basic human needs, the mental health crisis is really, it is so downstream for them. And I think I tangented too much. I'm sorry, Kristen. So
I don't want to interrupt you. That was very smart.
Can I just add one thing
Okay.
as well about this upstream and downstream piece? Because I think that's really where you were heading with that. And if my team in the room is probably laughing because they've heard me talking a lot about this and the ways in which healthcare, particularly safety net healthcare, when a patient arrives in our exam room, they're coming with the totality of multiple failed systems in their lives, right? Whether that's food access, education, et cetera. And the way that the system is currently structured, it is structured for this one-on-one engagement, and we can't sustain that. And one of the things, tying it specifically to the new arrivals crisis that I worry a lot about is that we have to have this emphasis on work permits, jobs, housing, food access. These are the critical needs right now, and meeting these needs will reduce the trauma of scarcity that people are experiencing. And I don't want to diminish the very real traumas, death, sexual assault, kidnapping that were also experienced that will require treatment. And the one-on-one model, as Evelyn was saying, may not be the only approach to this when we're talking about the demand significantly outpacing the supply. And so we have to get creative, and that's one thing Community Health has done for the first time ever. We've launched group programming for mental health. And we are trying to get creative. In addition to increasing providers, we're trying to think about this creatively. And I think as a sector, that's something we need to do, while we're also continuing to push this dialogue. Dr. Ige, and thank you for bringing this up, that our exam rooms have become the downstream collective, and it's not sustainable, whether it's mental health or primary care.
One more question for me, and then we're going to get to the fabulous questions you guys have in mind. I'll stop it here. Dr. Ige, I think this is on a lot of people's minds. Can you walk us through the city's approach to tackling the measles outbreaks that we've seen? But also, how are you getting ahead of potentially outbreaks of other diseases?
So you've heard a lot about the different pockets of work, and I need to situate the measles outbreak within the larger framework. When this started, there wasn't a sense of how big the issue was and what kind of infrastructure will be needed to support thousands of migrants. So it started in trickles, and it was like, yes, let's just sort out the basic needs, food, shelter, and that's all that's going to be needed. But I came from New York. New York has welcomed 183,000 migrants. So from the day that I landed in December, I was like, health is going to be a problem. And we had been very creative, had a lot of partners. People were coming, nobody knew what to expect. So buses were just arriving in the night. We've had over 1,000 buses and charter planes, and people just come, and there was no structure. So we were just piecing together whoever could come and do whatever. That was what was going on in the police districts, just trying to get by. And what we've done differently is put a structure in place, develop a system. And that starts from the landing zone. This is where people arrive. Even when they're dropped off at other counties, there has been conversations with the other counties, just route people to this central intake process. So that way we can screen everybody who's coming in for urgent healthcare needs. What was happening at the beginning was that we had all our partners coming and helping to screen and putting people on ambulances and sending them to emergency rooms. Last year alone, there were 12,000 ambulance runs. Each ambulance run is $3,000. So it's not a sustainable way of working that we're just, oh, you have a problem, get on an ambulance. You have a problem, get on an ambulance. The emergency rooms are overrun. So we had to create a system where we could identify what was urgent. We could treat people on site at the landing zone, and we could also determine who had an infectious disease that could become a problem when they're put in a congregate shelter setting. So we put that system in place recently. Now, when people leave the landing zone and go to the shelters, the health needs continue. So there has to be a way to identify what health problems there are. Is it an emergency? We cannot put everyone who has a cough or a fever in an ambulance and send them to the hospital. So how can we solve for those kind of issues? And that's where our partners come in and say, you know, this is a map of all of the FQHCs around. This is a map of all of the sites around. If you have this and if you have that, these are the places you can go. And if you have something that is an emergency, you're not able to breathe, you have a high-grade fever, you're having a seizure, then put the person on an ambulance and get them to the hospital. And we must have vaccination. Again, remember, prevent, protect, promote. Promote access to existing services instead of a belief that the city is just going to magically set up healthcare services for 38,000 people. That's impossible. We have to tap into an existing structure. But then, there are things that keep popping up because now we have 5,000 people, 2,000 people, 3,000 people in the same space that have not had a chance to have their comprehensive examination, and anything that gets thrown into that mix is going to spread. And so we've had little outbreaks here and there. But what is remarkable about measles is one of the most contagious viruses that we have. If you put measles in a room and there are people who are not vaccinated, 9 out of 10 of them is going to get sick. So the measles case that we had, the index case, was not in a new arrival, but we had a pool of unvaccinated people in our shelters. It was like putting a matchstick in a box of tinder. And it happened in our biggest shelter. That's a family shelter with a lot of children. So 900 people were exposed to that one case, because that's how measles is. If someone with measles comes into this room 2 hours after they left, the virus is still hanging out in the air. And so that was the task. And how do we make sure 23 shelters at that time can get their vaccination ASAP? We have only 32 nurses in the Department of Health, and we have thousands of people to vaccinate. So it's required an intensive level of collaboration to get people vaccinated, and we were able to do that within 3 days, get everyone who was exposed vaccinated, 900 people, within 3 days. It was working till 2 a.m. every day. And Dr. Figueroa was there on site, just getting shots in arms, and then rolling that across the shelter. But the lesson from all of that is we need a structure. We need a process in place. And so we're not constantly playing catch up, because there are 70 different infectious diseases that we're tracking, 70. So if it's not measles today, it will be varicella tomorrow. If it's not varicella, then it will be meningitis or strep throat or something or the other. So how do we ensure that there is a process in place to prevent from the get-go? And the system we're putting in place right now is tightening up our landing zone operations and front-loading the vaccinations. So before you get placed in the shelters, you get your vaccinations there. And then as you get through the landing zone, we have a strong partnership with Cook County Health. You get your appointment for your comprehensive medical exam thereafter. So you can have a real assessment of all of the vaccinations you require, and you'll schedule for that over time. And we are tracking who has received those vaccinations and who has not. And then the chronic diseases that we are all naming. So there's a behavioral health screening at Belmont Cragen. There is, connecting people to their medical home. And also there is a process right now to manage chronic illnesses that people may not even know that they have. So that's sort of the structure we have put in place now to ensure that as people are coming into the shelter, they get their vaccination, they get connected to a medical home, and they have an ongoing process. And another thing that is important to note is the new arrivals are eligible for Medicaid, but they don't know that. So if we don't get that information to them, then our systems downstream are overburdened because people don't know that they are, but the process takes some time to get them registered. So we're bundling all of these services. You come in, you get your vaccination, you get connected to your medical home, you get your Medicaid, and then you get that continuity of care. And we're planning for a surge in summer. Last year we were getting 2,000 people a week, and the numbers are inching up again. So if we get back to a scenario where we are seeing 2,000 people a week, do we have a structure in place to manage that? And so what we did is do a survey of all of our providers, who can provide what service, and how can we plug people, and who can we mobilize immediately and say, we need you at the landing zone in 24 hours, and who can go to different shelters. Some folks can only go to the shelters in their neighborhood. Others, some neighborhoods have support, some neighborhoods don't, who can move across neighborhoods, who can go to schools. So those are the things that we have mapped out so that if there is a need to rapidly ramp up, we know what buttons to press and we know how to support. So that has been the evolution of this process. It started out with people thinking it was going to be a small problem, and then the numbers began to build up at the police district and everybody was scrambling. And now we know better, and we are putting a structure and a system in place that can handle, peaks of up to 5,000 a week if we get there, and mapping all the assets that we have. I will end by saying that this has been an incredibly difficult process because unlike other emergencies, there is no federal funding earmarked for healthcare or health services. We've put in several requests and all of them have been denied. So we're having to do a lot with a little. So I know that there's an expectation of what the government can do, but now we're being extremely creative, and public health is always a team sport. So it's federal, it's state, it's county, it's all of our FQHC partners and community health care partner and CDPH. We have had to leverage every single resource to meet the needs in this crisis, and that's something to acknowledge because we don't have the resources we had. Imagine calling on volunteers to show up at the landing zone on a Saturday at 8 p.m. because we have 200 people waiting there to get vaccinated. They're not getting paid. Who's coming out on a Saturday because the commissioner calls you and say, come, So there is
That might actually be some.
I was like, there's some providers here. So.
Some people do, but if you've done that since 2002, yeah.
You mentioned how we could be getting a lot more migrants, right? I mean, that's the top question you all have in the audience is, what are the plans to address the anticipated surge of migrants prior to the DNC? Like, what are you all envisioning? What are you mapping out? I'm sure there's a bunch of scenarios playing out in your mind.
So we are anticipating at the minimum that we will get the similar numbers as last year. That's 2,000 people a week, with the potential of it getting as high as 5,000 a week. So what we're doing is mapping out overflow shelters, exploring partnership with the nonprofit, looking at some of the shelters we have decommissioned that may need to be rapidly brought back online if needed. Food is always a challenge because the city processes and the contracting, but putting contingencies in place if that needs to rapidly scale up. And then the health needs is humongous. Again, this is within the context of existing needs in the community. So we are also working very hard across all tiers of government, working with the US border system. Can you at least do some things at the border? The protocol right now is for you to screen at the border, do the vaccinations at the border, and not leave anything to the city of Chicago. That is not happening. If this was happening, we won't have to be investing so much here. So we're negotiating that. Can you at least do some part of the screening and the vaccinations at the border? What can the state support with? Even Each vaccine of varicella is $142. You know, just getting the vaccines alone is going to cost us $18 million for the adult vaccine, for varicella alone. And then MMR is $42 per shot. We don't have any grants or any funding to buy these things. So we're going around like, CD, can you give us some vaccines? Any other state that has a stockpile, can you give us, you know, some of it so that we are ready for this surge? And Cook County has been a wonderful partner. They can accommodate up to 150 patients a day, but if we get to 2,000 or so a week, how many additional staffing are they going to need? So we're mapping out all of these different scenarios. So that's where we are right now, to be sure that June, July, August, all hands are on deck.
We have time for one more question, and I think this one is very apropos because we've been talking about collaboration. This question basically is asking, how do we strengthen public health infrastructure and healthcare system coordination to better support this crisis and in the long term? Like, how do you all see us strengthening collaboration? Where are the gaps? Maybe name one gap that you would love to be able to fill in. How do you do that?
I would say the biggest challenge we have in the US is the concept of deservingness. Health right now is the responsibility of employers. You get healthcare coverage because you're employed and you have insurance. If you do not have that, then it is, you try Medicaid, but then you have to have 1 million qualifications to have Medicaid, and if you don't have all of those medications, then you fall within the cracks, and then what happens to those people? And that's what we've not been able to solve for in this country, that health is a human right, and everybody, regardless of who they are, should be able to get health services. Without that, government resources only go so far because it comes with all kinds of caveats. You cannot use it for this population, you cannot use it for that population, you cannot use this and you cannot use that because some people are deserving and some people are not deserving. And that is the constant advocacy. We get a little yield when it is people that look like us. So when you have, if you're a black person, then you care about black people. Then if you're a brown person, you care about brown people. And if you're a white person, you care about white people. But what if it is not a black person, or what if it's not a brown person? Then who cares about those people? And how do we get to a state where we have a system that serves everyone, regardless of the color of their skin, regardless of if they're employed or not, regardless of if they're migrants or not? This is one of the richest countries in the world. How are we not able to figure this out? The reason we're scrambling for this new arrival is not because there are not enough resources in the US. We welcomed 35,000 Ukrainians. Nobody heard of it in the news because we had the funding to do it. There are 50 million tourists to Chicago every year. Nobody hears a peep because they come with resources and we're able to scale. But now we're scrambling because we have migrants from Venezuela. This is the United States. I work for the United States Agency for International Development. We are the major funder for refugee resettlement around the world. We spend billions of dollars helping refugees everywhere, and we can do it here. So the public health infrastructure we need requires a change in our mindset. If that mindset changes and we believe that everyone is deserving, then we will have the resources that we need. We saw that during COVID, the resources are there, we will mobilize it when it's necessary, but not when they are brown people and not when they are black people. That's the problem we're trying to solve for. How do we change that mindset where everybody is deserving, and then we put in the resources to build structures that can serve everybody, not only people that look like us.
Very briefly, do each of you all want to join in there too?
I would add also the mindset is not just the institutions. I would say it's the mindset of everybody as citizens, and not only in this city, but also in the country. Because now, I've been hearing a lot for the last couple of years about the poor migrants, they don't have housing, oh, this and that. what about the 40, 60,000, whatever number it is, of the homeless people that we've had for decades? Why is it that we ignore that? Working with children, how come they're always at the bottom of the totem pole? Because they don't get money to contribute, they don't vote. So if you're marginalized, even if you're a large group, you get marginalized and we don't think about it. So I think in terms of the future to deal with those kinds of things, I think it starts with changing mindset. And I think also having every major stakeholder, government, community-based organizations, foundations, rethink the way we work together, rethink how things get funded, in the structures. One of the things that I really have enjoyed in terms of, despite the work and being overwhelmed, is like, it doesn't matter that I'm an executive director or that Stephanie the CEO and there's a doctor. Anybody can come and talk to me and say, hey, this particular individual needs help. It's not, well, you know, I'm the executive director, you can go to the family support worker, and that's their role, and vice versa. As a case manager in Mario, I need your signature here because we need the whole, it's more of a collegial effort across it, and I think that's also what needs to happen across organizations and between CBOs and government. Until that happens, I think we're just going to continue to stumble like we've done with other crises like COVID.
Dr. Figueroa, is there a particular gap you want to fill and have an idea of how to do that?
I'm sorry, I'm on a roll with them about the zero-sum mentality. So a lot of folks, they think that there's no money to do all of this. And Dr. Ige mentioned the 12,000 ambulance runs and the $3,000 per run. I'm sure who here didn't do the math in their head and come up with $36 million. If you didn't do the math, I want to see your hand, because I know everyone at least tried to do the math on that. What was your operating budget? 1.8, you said?
Just for that program. Yeah.
Just for that program, our operating budget is $390,000. For the Pilsen Food Pantry, we will serve at least 60,000 visitors this year. We presently serve 1,000 visitors every single week on $390,000. It's really important for us to think about that, to think, how are you gonna pay for this? You're gonna pay for it through prevention. We're gonna stop, I did the back of the napkin math for Pacific Garden Mission when we were trying to stop them from calling the ambulance 5 times a day in 2018. I looked at what people were calling for, and 2/3 of the time it was not an urgent reason, of course, because that's how we use ambulances in the United States, because people do not have access to basic health care. 10% of everybody does not have insurance, and the barriers with how we do it. I think that these are really the way, these are the gaps, this is how to solve it. It's to stop pitting us against each other. It's to not have signs that say, this is free, this person's insulin is, or Narcan is paid for, why do I pay $400 for my insulin? It's to not pit us against each other, because that's how they keep us disempowered. We have to really be nimble and creative and trust the kids, because the kids know what they're doing, and we need to listen to them. And if they question the status quo and the construct, and our knee jerk is, we can't do it, it's to stop ourselves and say, why am I saying no? Why am I okay with that person living under a viaduct? Why do I know that person's name? Because I've been giving them money for so long, and I have no idea how to help someone get housing. Like, we really need to question our individual acts, our financial acts, and then the values of the organizations with whom we participate and speak up.
And our political acts.
Absolutely. How did I forget that?
Steph, last word?
Yeah, so I guess I will be a little bit of an outlier. One, I certainly echo everything that my colleagues here shared. I mean, structural racism in healthcare is very real and manifests in many different ways, including someone who has employee-based insurance versus someone who's on Medicaid and the reimbursement rates. So we could probably do 3 other panels just about that. But a question I often get asked as CEO of an organization who's been working on the front lines of the migrant crisis is, what keeps you up at night? And my husband's here, so he could tell you a lot of things. But it's 5,000 people a week arriving on buses this summer. That's what keeps me up at night. And while we wait for significant structural change to occur, we also have some very real challenges here and now. And it's 5,000 people arriving per week this summer. And the fact is, our city was not ready for that last summer, and it was chaos. And when I look around this room, I see amazing supporters, but I also see our staff and volunteers who put themselves on the front lines and endured a significant amount of secondary trauma in the precincts, caring for people, providing dignity to people who had been given no dignity since the moment they crossed our border. And so when I think about the gaps and things that we can do now, it's really, again, we learned so much from the pandemic that is applicable now. We learned even more last year that is applicable now. And the fact is, community health has a set of strengths. MMHT has a set of strengths. CDPH has a set of strengths. Cook County has a set of strengths. Our academic medical centers have a set of strengths. And where are we leaning into the structures that have already previously been built, like the health equity zones, like just talking to each other and coming together and identifying, these three health centers that are around community healths in Enlace location, because my Enlace folks are here, they don't have capacity to take on uninsured patients, but community health does. How do we build systems or structures that ensure people know where to go? I think the example you gave about Cook County only having 150 appointments a day. Cook County's doing amazing work, and it's just not enough, right? As I say, despite best intentions and efforts, it's not enough. And so we have to now do what Dr. Ige had mentioned that the city has started to do, and resource map creatively and specifically, but also break down the barriers between organizations, so that, a large academic medical center isn't reaching out to me 3 weeks ago saying, we have a lot of people in our ED who are new arrivals and they don't belong here and they need to come to community health. How do we create those connections so that they're less reactive, they're more proactive, and that when we do have 5,000 people arriving to our city this summer, we do not repeat what happened last summer. That's not necessarily the hopeful tone, but there's a very real and now problem that we can solve for, and it is around building those resource maps, breaking down communications, really saying free and charitable clinics are exceptional at this, FQHCs are exceptional at this, academic medical centers are exceptional at this, safety net hospitals are exceptional at this. Now let's deploy on a regional effort in order to meet all of the needs of folks from a healthcare perspective, whether they're at the landing zone, whether they're at the shelter, or even when they get housing and a job, they still need healthcare.
All right, we're out of time. We're a little over time, so got my job. Thank you very much for discussing tonight. I'd like to wrap things up.
Just a few brief words. As I mentioned earlier, today's program was brought to you by Community Health. And just so you know, all of your ticket sales and donations that you make today will support Community Health's mission to serve those without essential health care. Please consider making a contribution and supporting this effort. There is a QR code on your table to make sure that you can donate online. Please take advantage of that if you can. On behalf of the board of directors and the staff and the volunteers at Community Health and all of our panelists, I want to thank you for being part of the 10th annual All in Chicago breakfast. I hope that you're leaving today with some new ideas and you're energized and you have ideas as to how to help advance this and make progress. We all want to meet the vision of access to care for all Chicagoans and make that a reality. We all have a critical role to play in this effort, and I thank you for being here today. Thank you for your support, and I hope you have an amazing morning. Take care.